bring up some of our practice questions. I'm going to, hopefully this works, trying some new automations. I'm going to put 2 minutes on the clock, and I want you to put your answers into the chat, and we'll spend a bit of time afterwards teasing apart and working out ways we can optimize your responses. All right, ready guys? Time starts now. All right, good to see some answers coming in there. Now, I wanted to just kind of highlight, and we might even go back one slide. You'll find this pretty commonly in the exams that they're not going to ask you necessarily what is the diagnosis. They're going to ask you things about, say, what is the severity of the diagnosis. This is where they're starting to tease apart, we know you know what the diagnosis is. What we want to know is how well you know that diagnosis. So I can see some fantastic answers coming in here. So we've got a reduced level of consciousness. The one thing I would be avoiding there, and just good to get in the habit straight away, try and avoid using any abbreviations. Now, in the actual exam, no abbreviations are allowed pretty much at all. Again, it's doctors marking it, and so if they see the odd one here or there, there's a chance that they'll let it slide. But the official kind of stance on the RACGP is not to use any abbreviations, not even AF for atrial fibrillation, for example. So just something to try and catch yourself on. And so I know it's probably just typed in tonight, just to have an answer there. But I would encourage you to just get into that habit of spell everything out. Even MRIs, magnetic resonance imaging, seems over the top, but it's what they've said from day one. But definitely good question. Good answer, sorry. Low oxygen saturations, fantastic. If we can, I'd try and get more specific on that. We'll talk about that in a second. Increased work of breathing, good, very good. And low blood pressure, again, I'd try and get a little bit more specific in those answers, but definitely on that right track, and you'd definitely be scoring marks there. So, some of the recommended answers here would be the acute onset confusion. And I think you would have got the mark there in terms of the reduced level of consciousness. It's more about that reflection of you're acknowledging the conscious state being involved. Now, tachypnea, so the respiratory rate, and this is where I was getting at some specificity. Where you can, try and specify what numbers you're classifying as high. And in this case, really, what the question's kind of teasing out is, do you know the criteria for CORB 65 or SMART COP, for example? And so here we'd be looking at respiratory rate over 25 or 30, kind of depending on which one you're really looking at. Remember, CORB is more your who needs to go to hospital. SMART COP is your who's going to need intensive support. And I think as long as you can kind of stick to one of those criteria, I think you get full marks there. Hypertension, again, just that specificity, systolic blood pressure under 90 or diastolic blood pressure under 60. The tachycardia over 125, because just tachycardia on its own typically would mean over 100. And in this case, for severe illness, we'd be looking at that over 125. And oxygen saturations under 93% on room air, again, just that specificity. Increased work of breathing or accessory muscle use, technically not a part of either of those criteria, but it is one of those situations where common sense prevails, and if you've got someone that's really fighting for breath, that is definitely going to be one of those things we're going to look at clinically for hospitalisation. So very, very well done. If you want a bit more kind of reading or sources for this, ETG have a really great section on assessing severity of pneumonia or community-acquired pneumonia in adults. So feel free to have a look at that. All right, let's go to the next part of this case. So question number 2, we'll put 2 minutes on the clock. Again, if you want to throw some answers into the chat, that'd be great. And your time starts now. All right, well done and good to see you again. Some really good answers coming in there. So, of course, we all know the photosensitive rash when exposed to the sun, and something you really have to warn everyone about with doxycycline. So I think we'll even go as far as, if this one's worked, gold stars for you there. Well done. Now, some other ones though. Again, this is a pretty classic question for KFP, where what they want to know is, you know the medication you would use in this setting, but can you tell me more about it? Can you tell me the side effects or the dangers of using it? Now, you're usually safe for these kinds of questions to spew forth the usual nausea, vomiting, diarrhea, which you can put for pretty much most medications. But doxycycline is as well quite well known to be irritating to the gastrointestinal tract. There is something that we haven't really talked about yet, and that is grouping of answers. And for some situations, you might be a bit nervous putting nausea, vomiting, diarrhea all as different answers. Again, just trying to keep your answers diverse, because they're all really the same thing as gastrointestinal, and they may actually all come under the same group and only be 1 mark, regardless of how many of those specific ones you put in there. Epigastric burning can be quite common with it, particularly if you're prone to ulcers or erosions. Tooth discoloration, which can occur in adults as well, but tends to be more transient in nature. We do obviously worry about the under 8 age group, where it can be a more permanent feature. Enamel dysplasia, again, while more common in children, can still happen in adults as well. photosensitivity, and I really loved your specificity. Again, I'm going to pop it back up there as well. Photosensitive rash when exposed to the sun, absolutely fantastic. Rash as well as just general rash can occur. Stomatitis, again, being that irritation there. Fungal overgrowth as a stripping of natural flora, and photoonycholysis and nail discoloration. One of the less common, more rare things that can happen, but is worth warning patients about, as if they do get it, it can be quite distressing. You just have to wait for the nails to grow out again. They essentially just lift off from the end, and that's when exposed to sunlight. And again, comes back to that photosensitivity. All right, well done. And of course, we are now up to the third and final one for this case here. 2 minutes on the clock, and your time starts now. All right, so time is up, and so happy to see some of the fantastic responses there. Of course, absolutely nailing it there. Nature's wonders, you are a wonder. Time to first cigarette after waking, number of cigarettes per day, and symptoms of withdrawal. And that would also include symptoms of withdrawal in previous quit attempts as well. Absolutely smashing it. Very well done. Another gold star heading your way. Now, again, this is a common trick you'll see in KFP exams where the first two questions are related and then they kind of mix it up a bit and play on some other aspect of the case history to assess a different part of your knowledge. In this case, it's part of the 5 A's. The first A is ask, and knowing what of those questions you need to be asking. Oh, sorry, the next bit is assess. There we go. And so assessing the nicotine dependence to plan out your further management. Again, I would want you to be very, very, very familiar with the RACGP smoking and smoking cessation sections on their website. Very, very common questions on the KFP exam, and just handy to know like the back of your hand for clinical practice as well. So very well done.